Hello and welcome again to Channels Television and to Health Matters. Thanks for joining us. I am Mary Alale Yusuf. The most common craniofacial abnormalities seen at birth are cleft lip and palate. According to the World Health Organization, they occur in about 1 per 500 to 700 of all births, differing in prevalence along ethnic groups and geographical regions. Cleft lip is a condition in which the upper lip is not fully formed, leaving a cleft or gap in it. Similarly, a child has a cleft in the palate when it's not fully formed. This separation can extend to the nasal cavity. In the studio with me is Dr. Akeem Alawode, a consultant oral and maxillofacial surgeon for the Lagos State Health Service Commission, a fellow of the National Postgraduate Medical College in Oral and Maxillofacial Surgery, and an associate fellow of the West African College of Surgeons. You're welcome to the program.
Thank you very much, Mary. It's a pleasure to be here.
Now, before we go to the clefts, tell us what is a palate. I'm sure a lot of people don't even know what the palate is.
Okay, thank you very much. A palate is what a layman calls the roof of the mouth. That's part of the mouth where when you roll your tongue upwards, that part of the mouth where it touches is a palate. It's the roof of the mouth, like I said. It forms a kind of partition between our mouth and the nasal cavity, that is the nose. So that is basically a palate.
Okay, so why, we know that it's not properly formed when it's cleft, but why would it not properly form?
Thank you very much. Before I go to why it will not properly form, let me just say that we have hard and soft palates.
Okay, hard
Those
and
are the
soft.
two major divisions of that part of the mouth.
Which one is responsible for taste?
The tongue is responsible for taste.
Oh, because you know, people have a saying that, you know, it's a bit strong for my palate. So I thought the palate also tastes.
No, the main the organ for taste is the tongue.
Is the tongue,
basically.
okay.
But you know that they all work together, the tongue, the palate, the other parts of the mouth, for us to be able to enjoy our meals.
Okay. Okay, so there's a soft and there's
a soft and a hard palate. So the palate, like I said, is a partition between the mouth and the nasal cavity. So why it is not fully formed? Yeah, it is, that usually happens in utero, as to why the baby is still developing in the womb. Yeah, and for the palate, let me start with the lip, for example. For the lip, this usually happens when the lip is about to form. That's from the 4th week in utero up till about the 7th week. Because there are some structures that are actually supposed to come together at that time. And when they refuse to fuse, there's a cleft of the lip. Now, for the lip, mainly, we have something we call the medial nasal processes and the maxillary processes. Once they refuse to fuse together, you have a cleft of the lip. But the palate, like I said, we have a hard and a soft palate. There's another division of a palate that we usually say we call it primary palate and the secondary palate. In most cases, when they say this patient has a cleft of the palate, they usually refer to the secondary palate. In his own case too, we have inability of fusion of what we call palatal shells. Those palatal shells are usually orientated vertically initially around, let me say, the 6th week in utero. The palatal shells are supposed to come together.
So it meets somewhere in the middle?
Yes. They are usually aligned by the side of the tongue.
Okay.
Vertically. So around the 6 to 7 weeks in utero, they're supposed to now align horizontally to fuse. So that usually happens. But patients that have cleft palate, that does not occur. Okay. So they now have cleft.
Now, the first question I will be asking you is, does this cause any pain for the child?
When you say pain, maybe you are looking at it generally. Yes, it will cause pain for the child if the child is not able to feed well. The child will cry.
It affects feeding.
It affects feeding. It affects speech. It causes ear infection. It affects psychosocial problems, especially for the parents of the child. But when you are talking about pain, as in physical pain, no. Unless there's an infection that is now associated with it, then we can now talk about pain.
Okay, now you said that the child can have ear infections.
Thank you.
How does that move from the palate to the or the lip to the ear?
Yeah, it's usually a connection between the palate and the ear, not the lip and the ear.
Okay.
Thank you very much. The soft palate is made up of about 5 muscular layers. Now, 2 of those muscles are called levator palatine muscle and the tensor veli palatini. These 2 muscles originate from the area of the ear called eustachian tube.
Okay.
They now insert into the palate. You are not seeing the connection.
Okay, so it's like a muscular failure.
Thank you, thank you. The eustachian tube is part of the middle ear. So now, when there's now a cleft of the palate, the eustachian tube is not able to perform the function it's supposed to perform. Because what the eustachian tube is supposed to do for the ear is to ventilate the air, to make sure there is equalization of pressure in the air. So when this does not happen, this patient will have accumulated fluid in that ear, middle ear infection.
Does the fluid come from what the baby is sucking?
Yes, let me explain better. Now, most of the time, the eustachian tube is closed.
Okay.
It only opens.
We can see it right there in the picture.
Yeah, it only opens when the patient is yawning, swallowing, or drinking or something. That's when it opens. Okay. Now, when there's now a defect in the muscles of the palate, those 2 that I mentioned to you, the tensor veli palatini mainly, and the levator veli palatini, you have a situation where this eustachian tube is permanently closed. So it's not able to perform its function.
No ventilation.
No ventilation, no equalization of pressure in that middle ear. So there's tendency for accumulation of fluid in the middle ear.
And of course, that's an invitation
for infection.
To infection.
So the patients will have otitis media, middle ear infection.
Does that affect the hearing eventually?
Definitely, hearing deficits will occur. And that's why in the management of cleft, it is usually multidisciplinary. It's not only the maxillofacial surgeon or the plastic surgeon or the general surgeons that deal with this management. ENT surgeons are also supposed to be part of the team, the geneticists, the orthodontists, and about 11 or 12 professionals, including the speech therapist.
Okay, you mentioned an orthodontist. Does that mean that there's a problem now with the formation of teeth?
Thank you very much. There's usually a problem with the formation of teeth, especially when we have a patient with an alveolar cleft.
Okay.
Yes. We usually hear of cleft lip and palate, but there's also a component called cleft of the alveolus.
Does that have to do with the gum?
The bone, that's the bone carrying the teeth.
The bone carrying
Yes, the bone carrying our teeth is called the alveolus. Now, when there's a cleft of that bone, the tooth that is supposed to come out most of the time, usually the canine, will not come out on time, or it might be rotated, not linearly properly. So in that sense, you need an orthodontist to help. But the surgeon too has to repair the cleft first. And we usually like to repair the cleft before the tooth comes out. There are different schools of thought. People want to repair when they're repairing the primary lip cleft. People want to, that's primary. The people want to do it when the patient is around 9 to 10 years. When you expect the canine to start coming, that's secondary.
So basically, the intervention here is surgical.
Yes, for cleft, the intervention is surgical. But there are also supporting things that we need to do, not just repairing this cleft. That is not total. Okay. We need to do other things.
When you repair the cleft, assuming you repair the cleft, but first let me ask you, what do you think is the ideal time to repair the cleft of the lip or the palate?
Yes, thank you very much. The ideal time to repair the lip, there's something we call the Millard rule. That is what we adhere to in Nigeria, and the Millard rule is international. It says that you repair a cleft when the baby is 10 weeks old. 10 weeks, that's like 2.5 months. When the baby weighs 10 pounds, that's like 4.5 kilograms. Okay. And when the hemoglobin level of that patient is at least 10 or greater than 10 grams per DL.
Okay, there was a picture that came up of the cleft and repairs. We're trying to show our viewers how it looks like after it's been repaired. Exactly. That's the A. So I think that person has bilateral cleft?
Bilateral cleft of the lip, the complete bilateral cleft of the lip.
Complete bilateral cleft.
We say complete because if you see that hole, that gap on both sides, is extending to the nasal floor.
Okay.
That's why it is complete. In some cases, the hole does not extend to the nasal floor.
Okay.
You see the lip is cleft, but it doesn't get to the nasal floor. It's incomplete clinically, but though people have said that although it's incomplete clinically, deep within, it's still complete because the muzzle is not coming together.
Okay.
Because the muzzle, the orbicularis muzzle on that lip might not come together, though the skin is coming together.
Okay. The A becomes the C after
now,
repair.
The A becomes the C.
And that looks beautiful.
That looks beautiful.
But you see those lines there. Is there any hope that those scars will ever go?
No, yes, they go. They go. That's why I did a study on the complications of wound healing following cleft repair. Yeah, because we usually notice that when we repair the cleft lip with a particular suture, it comes with crusting and when we now looked at it, we wanted to see whether the sutures that we use in repairing this cleft have an effect on the repair. But essentially, after the study, I realized no, it doesn't.
Okay, so let's just look at the picture A and B. B is supposed to be a complete cleft, right?
Both of them are.
They are both complete.
A and B are.
But look at picture D. The repair is extending right up the nose.
Now, that D, if I can see very well, is also showing that there's a cleft. So in that D is looking like a median cleft. It's not a very common one.
Oh, it's not a common
Yeah, it's not a common one. We call it median. It's just in the middle. It's not common. But what you have commonly, the commonest kind of cleft is the cleft lip. Okay. And it's commoner in the males. The cleft palate is commoner in the females.
But how about when it occurs together?
Thank you. We have people now that now have both the cleft lip and the cleft palate. So, but you also have patients that just have only cleft palate, they don't have cleft lip. So that's why the WHO classification, they usually, state the two of them together, cleft lip and palate.
And palate.
Yes.
Now let's go back to the feeding problem. This condition is discovered at birth sometimes.
Yes.
It can be discovered in utero, isn't that correct?
Yes, it can be discovered in utero.
Now, when the child is born, normally they will put the child to the breast. What happens with that kind of child who has a cleft? Doesn't the milk go in all directions?
Yes, thank you. That is one of the problems with a cleft lip and palate, feeding. Now, a patient that has just only cleft lip, the baby cannot maintain a seal over the nipple to be able to suck.
Because of weakened muscles,
that gap,
or just the gap?
It's the gap. Because of that gap, air comes out. The baby is not able to mount enough pressure. It's not able to mount enough pressure to be able to suck.
Okay.
Now, there's no seal, enough seal to be able to suck the milk. The one with the cleft palate is even worse. Because normally without a cleft palate, when you take, when we drink water, when we eat, the soft palate, that's the back part of our palate, usually moves to align to the throat, more or less sealing our mouth from the nose.
Okay.
And we mount enough pressure or suction with that to be able to drink or do anything. But people with cleft palate, they are not able to do that. So one, they are not able to mount, babies are not able to mount enough pressure to be able to suck. The baby will use a lot of energy and cannot be able to suck enough milk. That's one. Then two, they have regurgitation. The milk goes into the nose. That can also cause some infection. So there are different methods now of making babies to feed properly. For the lip, if the baby just have only lip cleft, the mother can still be able to suckle this baby with the breasts. So what she needs to do is to put the breast, you can use the breast to cover the defect. Okay. The soft tissue of the breast will go in and cover the defect and still be able to give. If the baby does not have cleft palate at all, that's what I'm saying, just cleft lip.
Just lip.
Some people have also said that the mother can use one hand to close the cleft lip together, then suckle the baby.
Okay.
But we have feeding bottles to different feeding bottles.
I need to stop you there. Let's go on a quick break. When we come back, we'll continue from there. Let's go on a very quick break. Stay with us. We'll be back in a minute.
Thank you.